Okay, well, welcome everybody. Welcome to the 28th Annual Wiley Visiting Professorship. Also like to welcome our medical colleagues who are joining us for their grand rounds today. And as is a custom, I'd like to acknowledge that Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on the territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis people and their valuable past, present, and future contributions to this land. So it's my honor to kick off the Wiley Visiting Professorship, and this is named after Jim Wiley. And if I can get this to go. Just can't get it to advance. There we go. Jim and Dr. Bill McIntosh really were the two that started orthopedics here at CHEO back in 1974. And Jim was a graduate of the University of Ottawa in 1955. He practiced at the General before he came to CHEO when we opened in 74. He was very active in research and medical education. He achieved the rank of professor of surgery. He was an assistant dean within postgraduate medical education. He was coordinator of the medical faculty alumni. He held many offices in orthopedics, including being president of the Canadian Orthopedic Association. Jim had many talents. He was a wonderful teacher. I was a benefit of that very early in my career. He loved to write. He loved to tell stories. He wrote 3 books, and this is one of them here. These are little books of anecdotes of his career, his practice, many of them, of course, focused on his life at CHEO. I think the one in 1996 he wrote right after he had his cardiac surgery. So he stayed active, and his most recent was the one in 2006. He was a gentleman. He was absolutely adored by his patients. And so in his honor, we inaugurated the Wiley Visiting Professorship in 1997. Sadly, we lost him in 2008. Ironically, it was the day before the visiting professorship that year. But I know Jim, and he would be delighted with the tradition that we've carried on here, and especially the caliber of the visiting professors that we have attracted. And this year is no different. This year we have Dr. Amy McIntosh from the Scottish Rite Hospital in Dallas. I turn the mic over to Andrew, who will introduce Dr. McIntosh.
Get my slides up here. I had to make some notes. I'm not a pro like you, Jay. I'm kind of an amateur. It's I know, but I don't see my PowerPoint open anymore. Just one slide of a nice picture. It was here, right?
Go.
There's too many open. Yeah. Oh, no, that's the troll. Found the picture. There we go. Okay. Well, I have the honor and privilege of introducing one of my great mentors, Dr. Amy McIntosh from Scottish Rite Hospital in Dallas, Texas. We had the opportunity to have some fun last night for our journal club, and then wander around the market a little bit. Dr. Smith, who was also down in Texas, joined us for a drink in the market, and of course, a picture with the Ottawa sign. And we had a lot of good discussions last night. Dr. McIntosh is truly a triple threat. She has extensive leadership positions, a robust research presence, and of course, clinical expertise. A little bit about her background: she did her orthopedic residency training at the Mayo Clinic, and then went on to her fellowship at what was then called the Texas Scottish Rite Hospital for Children. After her fellowship, she went to work at the Mayo Clinic for 7 years until she got the call back to the mothership and went back to Texas Scottish Rite for the rest of her ongoing career. She has a practice in general pediatric orthopedics with a focus on complex spine deformity and early onset scoliosis. She's a professor at the University of Texas Southwestern, and she has many, many leadership positions, including with our preeminent society, the Pediatric Orthopedic Society of North America, on the Safety and Value Committee. And I think you'll hear about some of her enthusiasm with standardization this morning. Above all else, you know, Dr. McIntosh really exemplifies going above and beyond. And I'm grateful for all of the lessons that she taught me about providing exemplary care for patients and just being a good colleague. So we're all very thankful, Amy, that you could take some time to be with us in Ottawa.
No, do that. Like there. No, like we're working.
You know, yeah, you go back there.
Right there.
Let me start sliding.
Okay. Oh, go there. Okay.
Nice.
So look at his baby face, Dr. I know. So thank you so much for having me. I've been to Ottawa once before, but it was just for the day. And I did see the hospital a little bit, but this will be, you know, a much more immersive experience. But Dr. Schmidt holds a very big place in my heart because he was the first class of fellows I'd ever had the opportunity to teach. When I was at Mayo, I got to teach residents, but I never had the opportunity to teach fellows. And so that is just an entirely like new level and a new experience. And then I do Dr. Tice's class. They were the all boy class. He still wears his belt buckle. And then here's a very nice picture of Dr. Jarvis and Dr. Birch. So Dr. Birch is, you know, one of my partners. He's a Canadian, but he's also an American citizen. And I know you guys have had a lot of good times together. And we had a great time last night at Journal Club. And I appreciate the opportunity to speak here. Are we not sharing?
No.
Oh. New share.
They gotta
Share
see that
again.
picture.
You are screen sharing. Is it working?
It is now.
Oh, thank you. I can hear you. Okay. I was showing you Dr. Tice. He appears to be aging in reverse. He's like Benjamin Button. And then the last time I was here, it's advancing here, but not on the screen. Should we try again? Oh, you can. That's weird. Okay.
But not in person.
But not in person. I'm going to just, should I stop the share and do it again?
One more time.
One more time. I'm like, third time's a charm, huh? I'll try this one. Okay. We are sharing. No, no, no. I think we've overwhelmed the system. I know. What about if I go this way? Okay. Got
You
it.
need now to put it in presenter view. We see the second slide as well.
There. Okay. Can you see the slides as well?
Yes, we can see the slides, so it needs to be presenter view. At the moment, we see both slides. What's coming next?
Okay.
I think it's from the top.
So bad. Okay. I'll just go.
We just do it in presenter mode.
Yeah, I'll stop. And then screen share. So we're here.
There's a lot of them.
I know. I want to hear what this.
I don't know. I think try that.
Try this one.
Yeah.
Share.
Perfect.
Good,
Okay.
Claudia. Can you change
Okay.
slides now, though?
Yes. Okay. Better?
Amazing.
Okay,
Thank you.
You're welcome. I apologize for that. But yeah, so the last time I was here, the weather was much more different. And it was a beautiful day. And I pointed out this picture in Dallas. I don't understand this because I'm originally from the north, but whenever you take a picture, they think you look better if you point your toe forward and put your hand on your waist. And so I call that the Texas toe point. And we have a very large like media department in Dallas. And so you almost get like training on like how to take an appropriate picture in Dallas. So now whenever someone tells me to take a picture, I automatically like take off my name tag. If I have a drink, I put it down and then I Texas toe point. And it's a little disturbing that in 10 years that has happened to me. But I made all the gentlemen Texas toe point in this picture. I am a consultant for invasive. Really, I just help them try to figure out ways to help EOS patients get better with early onset scoliosis surgery, but none of that has anything to do with the talk that I'm going to be presenting next. And if you haven't been there, this is Scottish Rite. So it's literally in the heart of Dallas. You can see it's on this beautiful green campus. And a little bit about Scottish Rite. So it's a standalone pediatric orthopedic hospital. We always say it's kind of like a shrine hospital. I know you have shrine hospitals here in Canada, but it is not at all associated with the shrine. They're both Masonic institutions, but we don't have any really working relationship with them. It is the largest pediatric orthopedic fellowship in the world. So we train 5 fellows a year. We have 3 locations. One is in Dallas proper. The other is in Frisco, which is kind of a suburb of Dallas, 22 miles north. That is an outpatient hospital that does a lot of trauma and sports. And then our 3rd location is at Children's Medical Center in Dallas, which is a level 1 trauma center. We have 9 operating rooms, only 52 beds. 5 have what we call an elevated level of care. We do not have an ICU. We do not have a blood bank, but we do about 4,000 surgeries a year and 350 spines a year. So it's pretty efficient with the space that we have. And then this is the Frisco campus at the top and Children's at the bottom. This is the staff we have. So this is our orthopedic surgery staff. And then we also have neurologists on staff, dyslexia therapists on staff. We have a dentist. And then we have consultants that come in for like neurosurgery and some other things, but really the only surgeons in the hospital on a daily basis are the orthopedic surgeons. We have 6 practicing spine surgeons. So these are me and my partners. And I was telling the residents that COVID for us actually was beneficial because the hospital shut down for a month. And the way we had been practicing, we weren't going to be able to continue that kind of normal practice post-COVID just because of the way our rooms were set up. It was kind of like a 5 rooms shared a common bathroom, so we wouldn't be able to like have appropriate social distancing. And the way the rooms were set up, we just weren't able to continue that. So we had like a month reset. And so really we had not a lot other to do. So we all just had a bunch of online Zoom meetings and we literally completely overhauled how we were going to treat AIS patients when we opened back up. But it worked out because they're healthy patients. We don't have an ER, we don't have an ICU, and they weren't in school. Like all school was shut down. And so honestly, we did more volume of AIS surgery once we reopened post-COVID than we had done, in the previous year almost, just because everybody's like, I need spine surgery, let's get it done. And so we kind of we got a lot of patients to go through the system, and we got to test like a lot of the standardizations that we kind of put into play during the shutdown. So I'm going to talk about, that's what I'm really going to talk about, is how we have Epic. I know you guys have Epic. Epic started when Dr. Tice was a fellow. It was late 2016, early 17 that we got Epic. And because we are the smallest hospital to have Epic, they didn't want to give it to us. We had to convince them. We had to go to Epic headquarters and like convince them we were worthy, which kind of seems interesting. But because we're so small, we have like a very integrated Epic team. And so basically we have been able to use Epic to kind of garner data for us and to kind of, you'll see in my slides, it kind of creates pathways for us to do a lot of very quick research and projects, but we don't need to have a lot of trainees or other people helping us because the computer is basically the data collector for us. So I'm going to kind of show you how we did that. But what I'm talking about, if you don't know what adolescent idiopathic scoliosis is, this is adolescent idiopathic scoliosis. I picked this because I thought it might represent a typical Canada patient. Yeah, yeah. Because it sounds like here, you know, sometimes the curves get a little bigger, you know, definitely above the 50-degree curves that a lot of places in the United States say. So I thought this would be representative, but this is what the patients typically look like. I think you guys see that. But the reason why we talked about it last night, adolescent idiopathic scoliosis for us was a good thing for us to standardize and integrate the medical record in, is because we do a consistent volume in it. So we do 130 to 150 cases a year. We talked about it last night. It's a very homogeneous patient population. It's easier to standardize things when the patients are very similar. So for us, every single year, because I look at the data every single year, this is what the averages are. Their average age is 14. It's a 30-70 split between males and females. Their average BMI is 21. Their average Cobb angle ranges from 60 to 62 degrees, and our average levels fused is usually 11. And this has been consistent for probably the last, well, since Epic, so for the last 5 years. So we have then taken our standardization and we've broken it up into preoperative, intraoperative, and postoperative. So preoperative standardization now, every patient goes into the EOS machine. I know you guys have one here. We send that information back and it gets measured by the company. And then the company sends us back this report. This report gets uploaded into Epic. So now once it's in Epic, it can automatically integrate into all of our clinical notes. So when we're seeing patients in clinic, but also when we're doing surgery, this is our truth. This is what we use when we're filling out all the forms that I'm going to show you. So instead of having a resident or a fellow measure, and that's what's getting put into all these forms, all of the information that gets put in comes from the data that Epic has sent back to us. And all we have to do, as you can see to the side here, we just pick the time point at which the x-rays were obtained. So we just go in and say, this x-ray, this data point, all these data points are at whatever, you know, this is. So as a clinician, you have, Epic doesn't know. So you have to tell Epic what these data points, at what point in time they represent. And then obviously we get this rotational profile. We like to look at these pre and post-op, but these are all integrated into our electronic medical system as well. We've been doing that for about 3 years now. So I think some of the fruition of that data will come into the future. As a group of spine surgeons, again, during kind of the shutdown a little bit, we met at 6 a.m. like every 2 weeks. I felt like it was for like 2 years, but it probably wasn't that long. But we all agreed to do exactly the same thing. So when an AIS patient comes in, it's not the McIntosh plan. This is an AIS patient, so they're on like the AIS plan. And so everybody gets preoperative labs 8 to 10 weeks prior to surgery, because we want to know. We had an issue with a lot of iron deficient anemia where they're coming in for surgery with hemoglobins of like 7. And you're like, well, it's hard to do elective spine surgery on someone with a hemoglobin of 7. So if they have a hemoglobin below 12 and a low MCV, they just go on to iron therapy. And if their vitamin D is low, they go on to vitamin D therapy. And we're trying to get them on these therapies at least 8 to 12 weeks before a scheduled surgical date so we can kind of optimize them for surgery. And this is just routine now. Everybody does it. Interoperatively, this was another thing that changed. These guys will remember that when we did spine surgery in the past, every patient got an epidural placed at the time of surgery, and that was our major post-operative pain control. But again, if they got the epidurals, they had to go to this area of the hospital where we couldn't socially distance, and there was a shared bathroom, and that was just not acceptable in COVID times when there were no vaccines, and the only thing we had was social distancing and masking. So we had to have all the patients be able to go to private rooms with private bathrooms. So we decided to integrate liposomal bupivacaine, which is basically a long-acting bupivacaine that lasts for 72 hours. And we put it in what we call an open erector spinae block, which is basically at the time of closure, we just inject the muscles and the skin around the spine with this cocktail of liposomal bupivacaine, regular Marcaine, and some saline to dilute it. But every surgeon did it in exactly the same way. Like I created a little training video that they all had to watch, and then they all had to take a test on how to exactly do the infiltration correctly. And then still, just like everything with standardization, you manage to find roadblocks. So what we noticed was people were not paying attention to where the ribs were, and they were just sort of like jamming the needle in. And so we were getting some iatrogenic pneumothoraces. So then we had to integrate that after the local infiltration occurred, that we had to get an on-table x-ray to check for a pneumothorace before leaving the operating room. There's been some other changes. We've gone to like a smaller needle. I've done some more training and education on the plane to, you know, put your needle in. And we do some specific training with the residents and fellows when they come on, just to be aware of where the lungs exist compared to the paraspinous muscles. And we haven't had a pneumothorax now in about 18 months, but for a little while, we're having one every maybe 4 to 6 months, which is very unacceptable. So we've managed to work around that obstacle. We also have a lot of checklists. So in the OR, before we close fascia, we have to go through this checklist, but basically it's a way for us to communicate with everybody in the room, including anesthesia and nursing staff, about what the plan for the patient is. And so you can see one of the lines here is, did we fuse the correct or planned levels? And did the nurse enter that into Epic? And so that we can make sure that what is being put into Epic is exactly what we want and that it is very accurate. So we talked a little bit about this already this morning. They're like, can you guys do 2 spine surgeries a day? And the answer is yes, we can, but you have to be a little selective. So I have what I call the McIntosh rules for 2 spines a day. So otherwise you just get yourself into trouble because of timing and, you know, using your resources appropriately. So for me to do 2 in a day, they have to have a diagnosis of AIS. It's really hard to do complex neuromuscular syndromic and do 2 in a day. They have to be healthy. I don't like to go below L2. They have to not be really large, so a BMI less than 30, and in moderate curves. Like you don't want to do 2 90-degree curves in a day, just because if you get into neuromonitoring issues or other things, it's just going to delay. So I think if you set up some reasonable rules, you can easily, we can do 2 spines a day. I know in your system, with sharing operative suites with all the other surgical services in the hospital, that might not be a reality here. But I do think it's important to show that for safety and efficiency, it can be done in the right system. This was a really nice thing we did in Epic. It's called our Spine Smart Form. So when we finish the surgery, we immediately go into Epic, and the resident, fellow, or attending fills this form out, and you can see it's basically just a bunch of click boxes. But once this form is saved, the data from this smart form goes into 3 different buckets. So it automatically then uploads into our prospective research REDCap database. So all this data gets put into our internal research database. It also writes the operative note. So this is like self-preservation for the trainees. So once they fill out this form, they pull up the operative note, and the operative note is essentially written for them. And all they have to do is click boxes. And that operative note also allows us for standardized and accurate billing. And so every spine op note literally looks almost exactly the same, except for like the little differences that you picked on the smart form. And then third, this data goes into 2 separate quality databases. One, the data gets uploaded into Setting Scoliosis Straight's database, which is sort of a national and international database run through Harm Study Group. And the second is we have our own internal, basically we call it our dashboard, where this data goes into. And so honestly, this form takes 2 to 3 minutes to fill out. And if you accurately fill it out, you get this downstream effect, which has made, you know, that it just drives research and any quality projects in a really efficient manner. And so if you're not part of Setting Scoliosis Straight, this is what it looks like. I get a report from them once a year. I don't know that yearly reports are that beneficial to me as a surgeon, but basically I can kind of see where I am kind of like myself against this whole group. So I guess I'm a faster surgeon based on this data they sent me, and they send you little pretty pictures. My blood loss is not terrible. And then here, I like this because you can kind of see from year to year how I was doing on OR time, blood loss, length of hospital stay. It kind of just lets you trend that for yourself and against your peers around the country. And it has a little bit of international surgeons in it. So I said to my friend and partner, Dr. Ramo, why do we put all this effort to send all this data to the Harm Study Group? It's like our data. Why don't we use it ourselves? We should use our own data. And he was like, yeah, you're probably right. And I said, okay. So then he created a little group with quality. So Sharma's the director of quality. Anesthesia, he's also our director of medical information. And then Deepa is our data informatics director. So he, with this team, has created our own, what we call Scottish Rite AIS surgeon dashboard. It's run through Epic and Power BI. So then this is always constantly like updating with new data and regenerating. So at any time I can go in and look. So I just pulled this, and basically I pulled for 2023 just to see what it looked like. So again, freakishly, just like always, we did 149 AIS cases. It's the weirdest thing. It's always like 130 to 150. It's flat. It doesn't go up. It doesn't go down. It just stays ridiculously stable. And you can see the numbers. We do, you know, each surgeon does around 30. And then Dr. Rafton is only 20% productivity. So he does the least. But the 5 of us who do the majority of the spine surgery each do about 30 AIS cases. So then you're like, so that's 150 AIS, but if we do 350 a year, that's 200 spine cases a year that aren't AIS, right? So all of this standardization is hard to apply to the other diagnoses of spine surgery. So that's what I always tell people they need to keep in mind. This is all very much so for AIS because it's so standardizable, and it's hard to apply to neuromuscular syndromic, you know, pick any other number of diagnoses why you have scoliosis. But you can see at any time, I can see the blood loss per level views for my AIS patients. And this number just keeps growing because we just keep adding to this registry. So this number will change, you know, weekly based on how many spine surgeries I've done. And remember, I told you we don't have a blood bank. So if we don't have a blood bank, how do we predict our blood product needs for a week of spine surgery at AIS? We didn't have a very good process for that. But what I realized is we now have this data where we have a very accurate accounting of blood loss per level per surgeon. And we also have a CBC on every patient preoperatively. So then I asked the Epic team, can you build a calculator where we fill it out before surgery, and it's a patient and surgeon specific calculator. So now when a patient is being booked for AIS surgery, they just put in my name. They know my blood loss per level fuse because that's constantly being collected. We know the Cobb angle. We know if there's going to be osteotomies. We know how much they weigh. We know their estimated blood volume. We know if they're normal. They don't have anemia. We know the number of levels I'm going to plan on fusing. And we then use this to calculate what we thought the blood loss for that case would be. And then what % of blood volume for the patient that would be. And then this recommends, should we type and cross them for blood? Because we don't have a blood bank, so we have to order it, bring it in from the outside. Or is it safe to do the surgery without even type and crossing them for blood? So we created this calculator, and then I just let it go live, because now all this data just kind of churns, and I let it run for, I think it was 9 months before I pulled the data out. And the nice thing about with the way Epic is built now, when I want to pull the data out, I just call the Epic analyst and I say, hey, can you pull the data? And they hit a button and it creates a spreadsheet and it just sends it to me. I know. And so then I just looked at the data, and when I had them pull it, it was 9 months from go live. We had 68 patients that had cured in the system since the go live date. The Cobb angle was 61. The average number of levels fused was about 10. Post-op Cobb was 22. Average blood loss per level fused was 37 milliliters, and the predicted EBL was 430. That's what the calculator predicted the blood loss to be. And the actual recorded blood loss was lower than what the predicted calculator was. And it tended to overestimate by 65 milliliters, which we all know in spine surgery, 65 milliliters is not a lot. But what it was interesting is the difference between the predicted and the actual was less than 5% of total blood volume in 93% of the cases. And there was no differences between what the calculator predicted and what the actual blood loss in the OR was. And most importantly, 0 of those patients needed an allogeneic blood cell transfusion. And we actually sent back 26 units of red blood cells that we didn't use. So 26 units of blood were prepared that we didn't use. So now, if that calculator says, like, you don't need to cross-match any blood, we don't even type and screen you anymore. So now, if that says you don't need blood, we don't even type and screen you. And then during the case, if the EBL goes above 15% of total blood volume, an Epic alert comes up, and then they send a type and screen to the lab so we can cross-match blood if they need to. And we do have 4 units of O negative in the hospital at all times. But this has really helped, because in America, there are some times when they're like, we don't have as much red cells, we don't have as much platelets. So if we're not like ordering and sending them back, that's just easier on the local blood bank that we're using. And so this was an easy thing for us to do, because we have all of this data now that we can try to standardize processes. And for post-op standardization, this is my team. It's almost the same team as Dr. Ramos' team. The only difference is I have Brenda Matthews, which is right here. And she's like my little like Epic super user. Like, I'll just be like, Brenda, can you make me a blood calculator? And she's like, sure. And I'm like, cool. And then she doesn't understand clinical though, but she knows how to program Epic. So I just like tell her what I need, and then she'll show me an example of what she's created. And then I'll be like, yeah, that'll work. And then we'll like let these things run. And so I have to have a meeting with Brenda like every 2 weeks. So I've had a meeting with Brenda every 2 weeks since 2020. But by doing that, we can drive a lot of these processes through Epic, which is really nice. So then post management, like I said, we had epidurals, but we literally couldn't function post-COVID in them. So we had to immediately switch. So we went to this liposomal bupivacaine, but now the nice thing is we literally had 2 patient cohorts, right? We had pre-COVID epidurals, post-COVID liposomal bupivacaine. Everything else stayed exactly the same. And I just had Brenda Matthews basically create what I call discrete data entry. So we just created it so people would enter into Epic the things that I wanted to look at. And so then we just basically let that run, and I could compare narcotic consumption in these patients based on the two different modalities for pain control. And so we did that for a year, and they did well, but then I was like, how can we make narcotic consumption better? Nick Fletcher is a fellow from Scottish Rite who now works in Atlanta. He had published on giving patients post-operative steroids. So they would get a dose of dexamethasone in the OR and then 3 doses post-op, and he showed good results. So I'm like, let's add that. And again, it was a really easy thing to do because now it was all built in Epic, and all we had to do is enter the little box for how much dexamethasone they got. And so we just let these cycles run. So 2019, we had our epidurals. 2020, we switched to liposomal bupivacaine. 2021, I added the steroids. And then we just had 3 cohort comparisons to compare where the patients are very homogeneous and standardized. Everything is the same. The only difference was adding liposomal bupivacaine, adding the steroids, and then the narcotic consumption basically just got spit out to me in Epic. And because Dr. McLeod is an anesthesiologist, he just created a little thing in Epic to create a morphine equivalent calculator. So then if they got 5 milligrams of oxycodone, Epic would record that, but it would automatically convert it to a morphine equivalent. So then when it printed out for me, I just got it all in morphine equivalent so we could do statistical comparisons. But basically, we had these 3 beautifully matched cohorts, and then all we did is look at morphine equivalents. And what surprised me is that liposomal bupivacaine was equivalent to an epidural in the first 24 hours. I didn't think that was possible. I thought epidurals were the gold standard. And then when we added steroids, we decreased narcotic consumption even more. And basically, we just drove down narcotic consumption. So after the 2 cycles, patients were consuming 40% less narcotics compared to when they were just getting epidurals. We also decreased our time to ambulation because when you had an epidural, you had to have a Foley catheter in. And we also decreased our length of stay. So now the average length of stay is about 2.4, 2.3 days. They love the steroids. They feel great. They're not nauseous. They're hungry. They're a little manic, and like they chow their breakfast down and then they walk a bunch of laps, and they're literally at the end of day 1, they're like, I feel great. And I'm like, I bet you do. And then there's a little crash on day 2 because the steroids are starting to wear off. So I think my next move is, should I send them home with a little oral steroid to ride through the little steroid crash? So that might be the next move. But the nice thing is, because we have this great data, I was able to, publish this. And so I think it has moved the needle for a lot of people in, because I know narcotic consumption is an issue everywhere, but trying to minimize the amount of narcotics that these patients take around the whole surgical episode. I don't know that we can get to no narcotics, but I think we can continue to drive it down. So we published in JPOSNA and we published in Pediatric and Neonatal Pain. Also, infections, it did not drive up infections. I'm also in control of looking over all the infections in the hospital. So then I decided we can add this to all the neuromuscular and syndromic patients. And so now all the neuromuscular and syndromic patients also get the Exparel plus steroids postoperatively. And that has really helped drive down narcotics in them. And for them, then that decreases a lot of the GI problems, a lot of the respiratory problems, a lot of urinary retention problems. And then we also looked at, like, what if we do an ultrasound guided injection of the Exparel before we even cut skin? Can we decrease on table narcotic consumption? So we did a little run of that data, and the answer is yes, you can. So basically, it drove down on table narcotic consumption about 24%, but because it didn't do anything with post-operative narcotic consumption, our anesthesiologists felt like the amount of time it took to do the injection before the incision was decreasing the efficiency in the OR. And so they decided to stop doing it because it was adding a little time. And when we only have 4 rooms and we're trying to get 2 spines done a day, just adding 15 minutes to each case everybody felt like it was too much. Now we've gone back to just doing them open ESP blocks before we close skin. And then the last thing we were able to do with this data was kids do not like pokes. And so at Mayo, my friends from Mayo had done a study where they used a non-invasive hemoglobin monitor to track hemoglobin in their total joint patients. And I was like, well, if you can do it in a total joint patient, we can probably do it in an AIS patient because it's very homogeneous. And so I got a little grant from POSNA. And so I decided, can we determine if non-invasive hemoglobin monitoring is actually accurate in an AIS population? If you haven't seen a non-invasive hemoglobin monitor, it basically looks like a pulse ox machine, but it also gives you a relative estimate of your hemoglobin. This was my personal reading. So it said my hemoglobin was 15.8. It does tend to run a little high, which is I'm going to show you, but this is your oxygenation. And then this is, it's like a pulse pressure. It's like how well you're perfusing your digits. So I was perfusing okay. And so we just looked at AIS patients and they would get their blood drawn, and then within an hour of a blood draw, they would get the hemoglobin monitor put on their finger. And we did it at 3 time points. We did it pre-op, we did it immediately post-op in the PACU, and we did it post-op day 1 at 0,700. And basically it showed that they were very accurate. It was just the non-invasive monitor tended to run a little high. And then we did a little analysis. And basically, if the monitor told you that your hemoglobin was above 10.8 or above, you've never had a hemoglobin less than 9. And we don't even transfuse unless a hemoglobin is less than 7. So now if you're a patient on the floor, you get this non-invasive hemoglobin monitor on your finger on post-op day 1. If you're above the 10.8 threshold, you never even get a lab draw. And so now 85% of our AIS patients don't even get a lab draw post-surgically. So, and this was published in JPOSNA as well. So through, I'll call it Epic integration, I think and me and my partners being willing to like standardize and all agree to do the same thing. It was funny. There's 4 of us that are a little younger, and we were all more willing to like come to common ground. And when we came to common ground, like our most senior partners would be like, oh, I guess I'm the outlier. And we were like, yep. So you have to do what we want. But the nice thing is they realized that process is good, and they were willing to change their practice patterns, which had been in place, sometimes 20, 30 years, just so that we all were doing the same thing. But in standardization and Epic basically collecting the data for us, we've decreased narcotic consumption by 40%. Blood transfusions now are at about 2%. We have this calculator that helps predict how much blood we're going to need. So we're utilizing our local blood bank better. And 85% of our patients don't even get blood draw after surgery. And again, all of this data is collected on this little smart form here, which is super easy to fill out. And it's like self-preservation. The residents and fellows know if they fill this form out, like their op note is like written for them, like, and the efficiency has really gotten excellent. And we know that when we're looking at the data that it's accurate, and we're not having to go back and do a lot of double checking. And now with EOS doing all the measurements for us, like it's a very well-oiled machine. This exists in Epic. We have been working to have where you can just like go into the Epic cloud and hopefully grab it and be able to use all of the stuff that we created. But I heard it's been more difficult than we want it to be, but hopefully we can continue to work on that in the future. So that's all I have. I thank you for your time, and I'm happy to entertain questions. Questions? Because you guys have been Epic for how long?
I was outpatient when I started 20 years, but the inpatient OR stuff has probably been about 5.
5.
You get it piecemeal rather than
I know.
drop it. Yeah.
We got it
in your lap. all-
right. Like we had to create all this. Like this did not exist. But I feel like since we created it, it should be like an available option for, you know, all people to. Wouldn't it be great if we all collected data in the same way
And standardize everything.
and standardized everything?
It's, I mean, it's a ton of work for setting this up, and the shareability would be fantastic if it works across Epic. How much, when you're going back to review this data regularly, how often and what kind of hours are put into that? How much time does it take? What kind
Yeah.
of personnel does it take?
Epic's not perfect. It's a computer. So right now, what we're working on is that all the data that we're pulling to look at is being based off of the diagnosis code that's being assigned by the surgeon at the time of surgery. Because otherwise, you know, diagnosis codes can just like get associated at any point in the care process, and some are accurate and some are not. So now we're honing in on the most accurate diagnosis code tends to be the one that is associated with the CPT codes at the time of surgery, and that makes the data better, but it's still not perfect. So I always just start going in when I'm looking at the data, I just start looking for outliers. Like I was like 1,500 on blood loss, you know what I mean? Like that's a lot. And then you go in and you look, and I'll pull up the case and it's not AIS, you know, because it only gives you the data that it's being programmed to give you. So, but it's still the amount of work that it used to be, like to what it is now is, you know, dramatically improved.
What kind of team do you have for ongoing modifications? I mean, you know, sometimes we'll try and put in a request to change something on Epic, and it takes 6 to 12 months.
I know.
Just because we don't have a very big crew here, I guess you could say, for Epic optimization.
We have a very huge, like for the size of our hospital, our Epic team is ridiculous. Like every time Epic comes, they're like, you have like 65 Epic, you know, analysts for a 52-bed hospital. We're like, yes, but also again, you know, that way, if I need like that calculator built, that got built in 2 weeks, you know, but Scottish Rite has decided this is an investment they're like willing to pay for, right? And so you know, we have a lot of support. It's ridiculous. And you guys, so we probably have 10 times the support that your entire hospital has, right? Yeah.
But the important thing is that you're using the data for change, right?
Yeah.
You can understand the real-time data and make changes appropriate for patient care, which is really cool.
Yes. But I feel like maybe if other hospitals realize that a little investment on the amount of like Epic support you have can lead to changes like this, then maybe they'd be willing to invest in that if it's going to improve patient outcomes, you know, and improve standardization. I don't know, but it might be a way to try to get more support. I don't know how those negotiations go. Yes, sir.
So we talked about from the QSCI perspective.
Yeah.
There's quality, safety, and effort. What the value piece?
Yeah.
Have you been able to integrate Epic to pull out a dollar figure to how much you guys are saving?
That's the hardest part in Dallas, because Dallas was free care until 2012, 13. So we've only had a billing department for 10 years. And so the value part is by far the hardest for us on everything. I tried to just see like how much money does it save just to not do routine lab draws in AIS, like how much. They couldn't tell me. I know. And so we just hired a new CFO, and that person is really working on that side of the equation for us right now, the value side. But when you've never billed for 100 years and then all of a sudden you're trying to figure out the value side, it's definitely a work in progress. We still don't, they don't even understand like RVUs yet in Dallas. I know. But I think in 10 years, we'll have a lot better data.
You guys work there because nobody in this country should figure out how to have value for anything that we do.
And we're mission driven too, right? Like we're a mission driven hospital. We do tons of free care. Like I think maybe we could, add a lot of like true value in that space for countries like yours. Yeah. Yes, sir.
You feel that the predictive blood loss calculator changed your not technique, but to be more meticulous with?
That is a great question. I love that question. So the one thing I can't standardize how my partners manage blood loss, right? So we all have Cell Saver. Some people, everybody's got their own little tips and tricks. But what this did do is with the dashboard where it's constantly updating, you see outliers, right? So if one of the partners, like if everybody's blood loss per level is like 30, 35 cc's, and then one of the partners is 60, people are like, what's going on? And so it makes everybody work really hard towards the mean. So we're all just a lot more conscious of our blood loss. Whereas if you don't have that data, you honestly don't know. I have a little trick where, and I can tell you, it's I use Flow Seal and then Quick Clot. Quick Clot is trauma gauze. So it's basically the military designed it to put in people who are out in the field. Like if you get like an IUD to the leg, you just wrap trauma gauze around it and it's got all these coagulation factors in it. And I figure like, well, if it's good enough for that, I could probably put it, in my spine patient. So I do Flow Seal and then I put Quick Clot on the top of it. The little trick there is you can't wring out the Quick Clot. So I think my blood loss is slightly lower than some of my partners who use like APDs or laps, because they're just wringing those things out, getting every drop out. And mine, they just take it out and they measure it and weigh it exactly the same, but they can't wring it out. Weirdly, my blood loss is a little less than a lot of my partners. So I use Quick Clot. Some of my partners, they'll use the ultrasonic scalpel to do vasectomies and stuff, and they think that's lowering their blood loss. I've chosen to put my money on the Quick Clot instead of the ultrasonic scalpel, but we all have our little tips and tricks to diminish blood loss.
Like for individual patients, so say it was predicting that they need a unit.
Yeah.
Feel that with this, knowing that going in, has that reduced? I know you said you sent 26 units back, but yeah, you feel like the need for the rate of transfusion is lower?
It has lowered dramatically. So we had another paper that got put out in the literature probably in, I think it was probably 2017, 2018. Our transfusion rate was 17%. And what it showed was huge variability between surgeons. There was nothing, it was all surgeon. So by standardizing the process, like we sat down with anesthesia and we kind of made a list of rules, like what are the rules for actual transfusion? And we all agreed to them and we stick to them. So now we don't transfuse unless hemoglobin is below 7. If it's below 8 and they're symptomatic and you're like doing something on the table, anesthesia might decide to transfuse in the OR. But by just sitting down and all agreeing to a set of rules for which transfusion is indicated, probably has lowered it more than anything. But now, all these other little tips and tricks. We went from 17% in 2017 to in 2023, it was like 1.5%.
Seven is 70 Canadian.
Oh, sorry.
You see if there's a conversion rate.
Yeah.
Can you see if there's any?
Oh, I'm like, you guys do hematocrit? Yeah.
I don't know if there are online questions.
Yeah, are there any online questions? I could hear somebody. Yes.
Necessarily wanted, and that patients can be safely transfused at a lower.
They're not doing spine surgery and manipulating the spinal canal. So everything we do is to maintain neuromonitoring as well. And so basically for us, it's this like balancing act. Yeah, can you let them get to 6? Sure. But are you going to have neuromonitoring changes because the cord's not perfused? Maybe, right? So I think it's really hard to take adult trauma literature and, put it into spine surgery because we all have different priorities. And for us, our priority is patient wakes up and walks the next day is the priority of every spine surgeon and every family and patient. Nobody wants a straight spine and not walking. So that's a bad day. Yeah. So for us, that was our consensus: spine surgeon plus anesthesia, 7. But for other procedures, other things, will they let them drop below 7 if they're not symptomatic? Sure.
Amy, thanks.
Yeah.
That was a wonderful talk.
Thank you.
On behalf of us in Orthopedics and also all those that on the Zoom call.
Yeah, thanks
Thanks
for
so much.
being online.
Jealous of a lot of things you have
I
going.
know.
and-
We're happy to like try to share and help. I know that we have resources that, yeah, other people don't.
Okay, well, thank you.
Yeah.